Welcome everybody. I am Dr. Manar, lecturer of medical parasitology. Today I would like to talk about neurocysticercosis. This lecture will help you to know introduction, epidemiology, etiopathogenesis, types of neurocysticercosis, clinical manifestations, diagnosis, differential diagnosis, management, prognosis, prevention, and conclusion of neurocysticercosis.
Let's start with introduction. Neurocysticercosis is the infection of the CNS by the larval stage of the pork-tip worm Taenia solium. Infection may develop in any organ, including CNS, either parenchymal or extraparenchymal in subarachnoid space or ventricles. Also, infection may develop in eyes and muscles, and these are the most commonly involved organs. And the most common manifestation in case of neurocysticercosis is epilepsy, but can have several other neurological manifestations. After introduction, we will talk about epidemiology. Neurocysticercosis is endemic in most Latin American countries, sub-Saharan Africa, and rare in developed countries. And a study from North India found the point prevalence of neurocysticercosis 4.5 per 1,000, and in big farming community it is up to 15%. And the proportion of neurocysticercosis among patients with epilepsy is estimated about 29%, and in those with partial seizures it was about 50%. About life cycle of Taenia solium, as we know that Taenia solium requires two hosts to complete its life cycle. Intermediate host is pig, which contains the cysticerci, and primary these cysticerci are in muscle, and humans act as definitive host if infection occurs by consuming undercooked pork containing live Taenia solium cysticerci. Cysticerci develop into adult tapeworm, which release eggs in human feces, and eggs contaminate soil and vegetation when ingested by pigs, and human eggs develop into larvae, which pass through intestinal mucosa and reach various tissues. And the mode of infection can happen by accidentally swallowing pork tapeworm eggs in case of cysticercosis, and here man acts as intermediate host, and the infection occurs through drinking contaminated water or food, or by putting contaminated fingers to mouth, and in this condition is called external autoinfection, or by internal autoinfection. About etiopathogenesis, clinical expression, management, and the prognosis of neurocysticercosis varies depend on the number of CNS lesions and their stage, size, location, and host inflammatory response. And studies have identified a number of mechanisms used by these cysticercus to modulate host's immune response, such as protease inhibitor, which is called teniestatin, sulfated polysaccharides, parasite paramycin, and prostaglandins. Although cysticerci reach mature size within a few weeks, there is a period of several years between exposure and onset of symptoms, and when parasite degenerates, there is a brisk inflammatory response, and the seizures are thought to result not from the parasitic infection but from the host response. Let's talk about types of neurocysticercosis. Neurocysticercosis consists of two types: intraparenchymal type and extraparenchymal type. Let's start with intraparenchymal neurocysticercosis, most common form and seen at gray-white matter junction. Lesion may be single or multiple and range in size from a few millimeter to 1 to 2 centimeter, and commonly seen in children more than 5 years, but can occur in toddlers and infants. Seizures are most common manifestation of intraparenchymal type, and third may have associated headache and vomiting. And papilledema occurs in about 2 to 7%, while in 4 to 6% associated with neurological deficits. Seizures respond well to monotherapy. Cysticercal encephalitis result from large number of cysticerci in brain parenchyma with diffuse inflammation and edema. This cyst evolves through 4 stages. First, the vesicular cyst, which is viable cyst which contains clear fluid, then change to colloidal stage, after this granular stage, and finally calcified stage. This picture showing different stages of cysticercosis. After intraparenchymal type, we will talk about extraparenchymal neurocysticercosis. Most commonly occur in ventricles and called ventricular neurocysticercosis, or in subarachnoid space and called subarachnoid neurocysticercosis. About the ventricular type, can obstruct CSF fluid and cause hydrocephalus, and CT may reveal only hydrocephalus and no cysticerci, while subarachnoid type can occur in the gyri, fissures, and basilar cister. This picture showing different types and forms of neurocysticercosis. In picture A, there is many cysticerci viable, while in picture D, many calcified cysticerci. In picture F, there is a ventricular type, picture E, subarachnoid type, and picture C, calcified cysticerci. And there are other forms of cysticercosis rather than neurocysticercosis which occurs in brain. If it occurs in eye, called ocular cysticercosis, or spinal cysticercosis, which occurs in spinal cord. If it occurs in muscles, called muscular cysticercosis, and many other organs. And a single patient may have multiple types and locations of cysticercosis. Let's talk about clinical manifestations of neurocysticercosis. May be asymptomatic, and the most common manifestation is seizure. And headache is common, either unilateral or bilateral, and may reflect increased intracranial tension or vasculitis. About 16% associated with focal neurological deficits. Symptoms and signs of raised intracranial tension as nausea, vomiting, altered mental status, visual changes, cerebral edema may be present in about 12%, and in 5% associated with neurocognitive deficit, learn, learning disability, psychosis, and depression. After introduction, epidemiology, etiopathogenesis, and clinical manifestations, we will talk about diagnosis. How to diagnose a case of neurocysticercosis. Diagnosis of neurocysticercosis depend mainly on imaging. In imaging, we will start to talk about CT. And parenchymal cysts usually appear as single, small, less than 20 mm with ring enhancement and eccentric hyperdense scolex, and this is in case of colloidal stage. While enhancement indicates inflammations in colloidal stage, live vesicular cyst has no enhancing. About extraparenchymal cysts may show hydrocephalus, enhancement, nasal cisterns, and occasionally infarction. After CT, we will talk about MRI imaging. Superior to CT and detecting cysts in ventricles in case of ventricular neurocysticercosis. Small calcified lesions may be missed. And in this case, we will use other methods such as magnetization transfer image and the magnetization transfer ratio and flare and fast imaging employing steady state equation sequence for lesion which not visible on routine MRI. After imaging and diagnosis, we will talk about serological diagnosis using serological tests. Seropositivity depends on parasite load and endemicity, and there are false positive results and false negative results. False negative results occur in single lesion and in case of calcification, while false positive occur in other parasitic infections and the high percentage of false positive for patients from endemic area. Also, detection of anti-cysticercal antibody in the CSF by ELISA, and also assay uses lentil-lectin purified glycoprotein antigens to detect antibodies to Taenia solium in serum, and this test has sensitivity about 98% in case of multiple parasites and about 50 to 70% in case of solitary cysticercosis. Also, detection of circulating parasitic antigens in serum by ELISA with monoclonal antibodies is experimental. And in patients with reliable diagnosis of neurocysticercosis by imaging studies, immunological test is not required, and since a negative test won't discard a neurocysticercosis. We can do other lab tests such as Eosinophilia may be present. Also, we can do CSF examination, usually done to rule out other causes, and can be normal in inactive disease. And also moderate biliocytosis, mostly mononuclear cells up to 300 per cubic millimeter, and increased protein about 50 to 300 milligram per deciliter, and correlate with disease activity and whether or not the parasites are located in subarachnoid space. Also, we can do biopsy of subcutaneous nodules, And also we can do radiograph of skeletal muscles in case of cysticercosis in muscles. Also specific cobro antigen detection by ELISA for screening for Taenia solium carriers. And we can do stool examination for Taenia solium egg, which has poor sensitivity. This panel showing diagnostic criteria for neurocysticercosis. There are absolute criteria, major, minor, and epidemiological criteria. Definitive diagnosis occurs when there is one absolute criteria or two major plus one minor and one epidemiological criteria. And the probable diagnosis occurs if there is one major plus two minor, or one major plus one minor and one epidemiological, or three minor plus one epidemiological criteria. After diagnosis, we will talk about differential diagnosis. Neurocysticercosis can be differentiated from tuberculoma, microabscess, toxoplasmosis, fungal lesions, low-grade astrocytoma, cystic cerebral metastasis, and CNS lymphoma. After this, we will talk about management of neurocysticercosis. First, we will talk about emergency care. Manage seizure activity by supportive care, monitor and correct metabolic abnormalities, give anticonvulsants are effective, antibiotics. Also initiate proper diagnostic procedures such as blood work and imaging. How to treat a case of intraparenchymal neurocysticercosis? Either symptomatic treatment, antiparasitic treatment, or surgery. In case of calcified cyst only, give anti-epileptic, analgesic, and anti-inflammatory drugs for seizures, relapse, and repeat imaging looking for pre-calcification edema, and AED for at least 2 years since last seizure. No antiparasite drugs given in calcified cyst. In case of one or more cystic or degenerating lesions, give anti-epileptic, analgesic, and anti-inflammatory, and give also antiparasitic treatment under hospital conditions with steroid treatment, and discontinue EED and single lesions after they resolve without calcification. In case of cysticercal encephalitis, manage intracranial hypertension and don't use antiparasitic drugs. In case of asymptomatic parenchymal lesions, give prophylactic AED not justified in calcified lesions without seizures. Viable cysts, give prophylactic AED when antiparasite treatment is also planned. And repeat neuroimaging after 3 to 6 months to document lesion resolutions, and repeat course of cysticidal therapy if persistent lesions. What about drugs? We can give albendazole, Praziquintal, combination of 2 antiparasitic drugs and steroids. In case of albendazole, give 15 mg per kg per day in 2 to 3 divided doses for 2 to 4 weeks. Shorter courses of 3 to 14 days tried in single lesions. And in Praziquintal, give 50 mg per kg per day, and Praziquintal less effective than albendazole. In case of combination of two antiparasitic drugs, increase the cyst clearance in multiple lesions. And in steroids, give dexamethasone or prednisolone. This image showing before and after treatment. In case of extraparenchymal neurocysticercosis, we can manage this case through, in case of basal subarachnoid neurocysticercosis, control of intracranial hypertension, long term 1 month or longer, and treatment with antiparasitic drugs with steroids. In case of neurocysticercosis of the synovial fissure, also we control intracranial hypertension and give antiparasitic drugs with steroids, and can do surgical excision. In intraventricular neurocysticercosis, neuroendoscopic excision, and consider third ventricle fenestrations or placing a ventriculoperitoneal shunt, and post-surgery antiparasitic treatment. And open surgery might be needed for fourth ventricle cysts. In case of small cysts in subarachnoid space, we treat it as parenchymal neurocysticercosis. In other forms of neurocysticercosis, such as spinal cysts, are treated with surgery, and albendazole with steroids is being tried. In subarachnoid cysts can migrate, so imaging is done just before surgery. And in case of ocular cysticercosis, surgical management is the standard of care. After management, we will talk about prognosis. In case of single lesions, has good prognosis and disappears in more than 60% at 6 months. Seizures recurrence is in 10 to 20% with single lesion, and in multiple lesions have more frequent seizures. Prognosis is poor in cysticercal encephalitis and in extraparenchymal type. How to prevent a case of neurocysticercosis, or how to prevent a case of cysticercosis in general? First, Taenia solium infection is one of a few diseases targeted for focal elimination and eventual eradication by the International Task Force for Disease Eradication. 2. Public education, proper hygiene and provision for toilets, and safe handling of meat, and strict animal husbandry and meat inspections procedures. Mass deworming of population with Niclosamide or Praziquintal. Mass vaccination of pigs and treatment of pigs with oxyfendazole. And community interventions reduce rate of epilepsy in hyperendemic areas. And finally, we will talk about a conclusion. Neurocysticercosis is a common cause of seizures and other neurological manifestations, and needs to be considered in the differential diagnosis of many neurological conditions. Treatment with cysticidal therapy leads to reduction in seizure frequency and faster resolution of lesions. And children with a single or few lesions have a good outcome. And finally, prevention of neurocysticercosis is important and feasible. Thank you.